That worked great. Hi, everyone. Welcome to our third session today of the 2024 Childbright Virtual Symposium. My name is Pierre Zweigers, and I am the Training and Capacity Building Coordinator for the network. This year's symposium is designed to bring together our diverse community of researchers, patient partners, and advocates to discuss key issues and share our collective expertise. It's a pleasure to have you all here today as we will continue with today's session. It's titled Shifting from Discovery to Implementation Science Research. As a network, we have learned a lot in the move from our phase one work, which has focused particularly on producing research in patient-oriented research, into phase two, which is all about implementation in the real world. Today's panel discussion will explore how we have moved forward and shifted our focus to incorporate elements of implementation science research in our endeavors. Before we get started, I just want to take a quick moment to introduce you to today's speaker, Dr. Janet Karan, as well as session co-moderator, Dr. Simone Collins. Janet is a professor in the School of Nursing at Dalhousie University and the inaugural Quality and Patient Safety Applied Research Chair at IWK Health. As co-lead of Childbright's Implementation Science Research Program, along with Dr. Stephen Miller, her work focuses on designing interventions to enhance healthcare practices and policies. Simone is a postdoctoral fellow who recently joined Childbright, and she is associated with the Strengthening Transitions in Care Lab, which is focused on implementation, where she's focused on implementation science research. She completed her PhD in pediatric neuropsychology at Monash University, and has recently relocated to Halifax to contribute her expertise to improving outcomes for children with brain-based developmental disabilities. Following Janet's introductory remarks on implementation science, we will move into a discussion with panelists that represent four of Childbright's phase two projects. So representing the Childbright Bridging the Gap project, I'm happy to have Lucy Lott and Kim McIver joining us. From the Childbright Care Pathways Project, Kelvin Lee, Marie-Eve Bolduc, and Jamie Lynn Hunt will be representing the project. From the Childbright Pain Pathway Project, I'm happy to welcome Lisa Kim and Sharon Howe. And lastly, from the Childbright VREF project, we have Jennifer Crosby and Gunjan Seth joining us. So without further ado, I will hand the virtual podium over to Janet, and yeah, take it away, Janet.
Thank you, Peter. And good morning and good afternoon, depending on where you are right now today. If you bear with me for a minute while I share my screen with you. Way. Start. Share. I had a funny conversation last week and it makes me want to laugh just as I'm about to say, can you see my slides? We had a really interesting conversation about how the new lexicon of sayings that are in Zoom meetings now are, can you see my slides? And you're on mute. The various things that we never said before, but now we seem to be saying all the time. So I am really pleased to be here to be a part of this discussion about your journey moving from phase one to phase two and how this all ties in with implementation science. So without further ado, I've prepared a few slides that hopefully will lay the foundation of our discussion. But I'd like to first begin this presentation by acknowledging that I am privileged to live and work in beautiful Halifax, Nova Scotia, otherwise known as Mi'kmaq, the traditional territory of the Mi'kmaq people, a land governed by the treaties of peace and friendship. And I want to express my gratitude to the Mi'kmaq people for being good stewards of this land. I also want to acknowledge that Nova Scotia is home to over 50 African communities whose culture, heritage, and histories have been and remain a key part of this province for more than 400 years. I have no conflicts of interest to declare. So my plan for this session is really to present you with some background information related to implementation science to set the stage for our panel discussion. I attempted to keep this pretty broad, so for some of you, this will be a refresher, and for others, there might be some new information contained within the presentation. Over the next 20 minutes, I'll talk about what is implementation science and implementation science research. We'll review what are some of the challenges and opportunities in the field, and spend some time talking a little bit about different types of implementation science research studies and designs. So what is all the hype about implementation science anyway? Well, significant funding and resources at the organizational, provincial, federal, and international level have been committed to clinical and health systems research over the past, 50 years. This research is producing new findings that, if implemented, could contribute to effective and efficient patient care and health system change. However, this will only happen if healthcare professionals and health systems adopt these findings. Unfortunately, what we know that there tends to be a consistent failure to translate research finding into clinical practice. Janet Squires, who's a colleague of mine at the Ottawa Hospital Research Institute, recently published a systematic review reporting on inappropriately used clinical practices in Canada. Their review included 174 studies representing 228 clinical practices across the country. And the median proportion of inappropriate care was 30%. With underuse or patients not receiving recommended practice being more common than overuse, and that is patients receiving a practice that is not recommended. So as we can see, the movement of evidence-based practices into clinical care is less than perfect. The field of implementation science evolved to tackle this problem. That is, to study how to facilitate the spread of evidence into healthcare policy and practice. It is specifically focused on that gap that many of you I know have heard about, this no-do gap, that gap between what we know is good evidence and what individuals or policymakers are actually doing in related to decisions. So that said, the wide range and variability in the types of implementation problems, so in the areas in which evidence is not being employed, can pose a challenge for building an empirical and theoretical basis in the field of implementation science. Some of these challenges can be attributed rather to the types of problems, but also the types of targets of interventions. So whether that might be patients or healthcare providers or policymakers, and the types of settings where these targets operate. So either in hospitals or in community settings, in schools, in patients' homes. So as you can imagine, all of this variability can influence the way in which an implementation strategy works or doesn't work. So studying implementation can be complex, but it's critically important if we want to make any headway into moving evidence into decision-making. So all that being said, though, there are some opportunities to advance the field. And one of those you may already be familiar with, that I know many of you used to develop your protocols, and that is the Standards for Reporting Implementation Studies, or the STARI guidelines. These were developed to promote transparent and detailed reporting of implementation studies. The expectation is that researchers would, through using the STARI guidelines, clarify both how they anticipate the strategy that they're suggesting should be employed and likely to promote implementation, as well as help to explain the underpinning premise of why implementation of that intervention may be expected to improve healthcare or health outcomes. Other tools like the Tidier checklist help with reporting details of the intervention elements. So the use of these types of taxonomies, frameworks, and guidance will help to build a body of knowledge in implementation science that we can use to replicate in future studies. So implementation science is a human enterprise, and the goal is to develop an empirical or theoretical basis to optimize implementation activities. Implementation science and effective implementation requires interdisciplinary and multi-sector collaboration between patients and/or members of the public, researchers, implementers, policymakers, clinicians, and other relevant research partners. And many of you on this call are part of these types of interdisciplinary and multi-sectoral teams. So we know that clinical practice often fails to change in response to recommendations published in the research evidence. The objective of implementation research is to identify the behaviors and strategies and the characteristics of multiple levels in the healthcare system that support evidence-based implementation to improve patient and community health outcomes and to better address health disparities. The goals of implementation research are multifaceted and largely fall into two broad categories: that of examining the implementation of evidence-based interventions, as well as evaluating the impact of the strategies to improve implementation. And this is in contrast to traditional effectiveness research, which seeks to assess the influence of interventions on patient outcomes. So there are two types of research that we'll be discussing today, but the emphasis will be on implementation research. Jeff Kern has developed a simple teaching tool, which I find very useful to talk about when we're trying to describe implementation science. And essentially, he describes the intervention as the thing. And then effectiveness research looks at whether the thing, the drug, the program actually works. So that is effectiveness research. Implementation research looks at how best to help people do the thing. So use the drug or be a part of the program. Implementation strategies are the stuff we do to try to help people do the thing. And the main implementation outcomes are how much and how well they do the thing. So the choice of outcome measures is a critical aspect of research design in implementation research. Distinguishing implementation effectiveness from treatment effectiveness is important to assist with helping us move these interventions into real-world practice. This framework on the slide was developed by Proctor and colleagues as a taxonomy to conceptually distinguish implementation outcomes from other types of outcomes. So in this list, you'll see starting with acceptability, adoption, appropriateness, costs, feasibility, fidelity, penetration, and sustainability are our primary outcomes for implementation research. And if you'll bear with me, I'll just quickly give a slight definition for each of those concepts to help provide some clarity around implementation research. So acceptability is the perception that a given treatment or service is agreeable or palatable or satisfactory. So that's the piece around acceptability. Adoption is defined as the intention or the initial decision or action to employ an innovation or evidence-based practice. Appropriateness is the perceived fit or the relevance or the compatibility of the evidence-based practice for a given practice setting or a provider or a patient, as well as the perceived fit of the innovation to address a particular issue or a problem. Cost is defined as simply the cost impact of an implementation effort. Feasibility is defined as the extent to which a new treatment or an innovation can be successfully used or carried out within a given agency or setting. So we might have a beautiful program or intervention, but the feasibility of it fitting in a particular setting may not be appropriate. Fidelity is defined as the degree to which an intervention was implemented as it was prescribed in the original protocol, or as it was intended by the program developers. Oftentimes we see programs are developed, but then as they roll out into a particular setting, they don't actually roll out the way the researcher had originally planned. Penetration is defined as the integration of a practice within a service setting and its subsystems. And sustainability is defined as the extent to which a newly implemented treatment is maintained or institutionalized within a service setting. So those are all important implementation outcomes, and I'm intrigued to hear how some of you may or may not be capturing these types of outcomes in the work that you're doing. Many of you on the call today are also very tired of us talking about or pushing the need to embrace theories, models, and frameworks in your research design. But I feel the need to once more emphasize their importance in 3 areas of implementation science research. First, they help to describe or guide the process of translating research into practice. Secondly, they help with understanding or explaining what influences implementation outcomes. And finally, they also provide a better understanding and explanation of how and why implementation succeeds or fails. And I think this is an important nugget in implementation research, is trying to make sense of why an intervention works or doesn't work. The challenge, of course, is that there are a huge menu of theories, models, and frameworks to choose from, and sometimes that can be overwhelming. So luckily, there are tools such as the TCAST, which was developed by Sarah Birkin and her team in the US in collaboration with some Canadian colleagues whose names you may recognize on this screen. And this tool can help guide selection of appropriate theories, models, and frameworks to support implementation projects. Implementation research designs share many of the foundational elements and assumptions of effectiveness research. Researchers have many study designs to choose from, and we'll probably hear folks on our panel talk about the different designs that they're using. And these designs are optimally suited to consider different types of implementation research questions and different circumstances. So the 3 broad types of study designs commonly used for implementation research are experimental, quasi-experimental, and observational studies. Some of you on this call have completed research design courses in your respective programs, but for those new to research design, I'll just give a quick soundbite to each of these types of designs. So basically the difference is that experimental and quasi-experimental designs feature a well-defined intervention that is manipulated by the investigator, and it is hypothesized to affect outcomes in a specific way. And generally there is a group who doesn't get the intervention or gets a different type of intervention, and those 2 groups are compared. Whereas in observational studies, they are typically used to describe events or experiences as they unfold, and are meant to help understand implementation strategies, the context of implementation, as well as implementation processes. So what we know is that enhancing the uptake of evidence at an individual or system level generally involves some type of change. So to that end, understanding at the front end, understanding the barriers to implementation is an important first step to implementation research. And a variety of methods can be used to collect data to understand barriers, including observing the practice in action, focus groups where you speak with people who use the intervention or are impacted by the intervention, individual interviews, and questionnaires. And then I'm going to go back to plug using theories to guide data collection and analysis would be important to assist with developing our good understanding of the factors that are posing as barriers or influencing the uptake, as well as helping to, these theories also help to design the interventions to address those barriers. And I put a plug in there for a program from NHS, which is I think a really well formatted program, if you will, or guidance on how to change practice. So this guidance is really about how to collect barriers to change and then what to do with that information. So there's no shortage of tools out there to help you. The traditional research pipeline has encouraged a staged approach to evidence-based intervention development that historically is focused on ensuring an intervention, like a drug or a program, works under ideal conditions before consider translating it into the real world. Now, as you can imagine, if we follow this pipeline, it then takes a long time to move into uptake in the real world. And so there is now a thought that instead of separating effectiveness research and implementation research, that we really begin to think about how we can put those two types of research together to help us understand some of the complexity that slows down the field of implementation science. So thus, I'm going to talk to you a little bit about hybrid effectiveness implementation designs, which offers a potential solution to this problem. They are designed to promote the examination of both effectiveness and implementation outcomes within the same study. So hybrid design refers to a specific aspect of the procedure pertaining to the focus on either effectiveness of the intervention and its implementation in the same trial. Therefore, many types of randomized and non-randomized trial designs can be used in the context of a hybrid design, and it really depends on your research question. So the three broad types of hybrid designs that vary in terms of their emphasis on either effectiveness versus implementation outcomes are starting with hybrid type 1, which focuses primarily on effectiveness outcomes of a clinical intervention or prevention intervention, while exploring in type 1, you explore what are those factors which might impact the implementation of this intervention. In hybrid type 2, this has a dual focus on both effectiveness and implementation outcomes. And these designs allow for the simultaneous testing or piloting of implementation strategies during what would normally just be an effectiveness trial. And finally, in type 3, it focuses more heavily on implementation outcomes while also collecting some effectiveness outcome data. So you can see in the top part that line that moves from effectiveness research to implementation research, the emphasis changes as you go from type 1, type 2 to type 3. So by not concurrently gathering effectiveness and implementation data in the same trial, investigators may be unaware of crucial contextual factors related to the success of their intervention and risk significant delays in effective implementation of a clinical intervention. When describing their design, it is important for researchers to adequately describe the evidence base for the intervention and the implementation strategy. It's important to select evidence-based implementation strategies and provide rationale for the selection of that strategy based on factors of the context, so where it's going to be implemented, the recipients of the intervention, and the innovation itself. So the type of intervention itself, so whether that be a program or a drug. Engaging knowledge user partners early and often can help to expand the traditional effectiveness studies, as the knowledge users can provide important input about their lived experience with these types of programs that may influence the type of implementation strategies that one chooses to use. So the final type of implementation research I want to talk about is process evaluations. And process evaluations are another type of implementation research that's centered around answering the questions related to how and why an intervention works. the extent to which it was implemented as intended, or the fidelity, which is one of the outcomes that we talked about earlier, and its relevance and reproducibility to other settings. So process evaluations provide important information that help us move an intervention into a new setting, so scale up and spread. So this is important background knowledge for that. They can address the limitations of effectiveness evaluations by examining the quality and quantity of what was implemented in the trial, the mechanisms underpinning the cause and effect of the intervention, and what factors in the context or the setting influence the outcome. So essentially, they can tell us why an intervention works and how it can be optimized in a different setting. Unlike effectiveness studies that often compare strategies and evaluate the effect of an intervention, process evaluations focused on whether the intervention activities were implemented as intended. It answers the who, what, where, when, and why of implementation. Process evaluations can be conducted as a standalone project or integrated into a larger effectiveness trial. Implementation research often operates, just as a point, often operates at multiple levels where interventions are trying to affect patients who are nested within an individual provider's practice, within a multidisciplinary team that is part of a healthcare organization, within a regional or provincial health authority. And we can continue on further in this Russian doll type of analogy, but the methodological challenges for trying to make sense of what has influenced the program or the drug that you're trying to implement or the intervention can sometimes be challenging, as you can imagine. So process evaluations help us to unpack where some of these factors are that influence the movement of the intervention. There is no single best way to design and carry out a process evaluation. Researchers are faced with choices about what questions to focus on and what methods to use. The most appropriate design really depends on the purpose for conducting the process evaluation. What is really important is the need to have knowledge users helping to identify what are the important outcomes, as well as what's the important research question. Often process evaluations use mixed methods approach, where they use both quantitative and qualitative methodology to do the work. So in summary, the emphasis of implementation science is on understanding how and why an intervention works. Implementation research should be grounded in theory to assist with building a generalizable knowledge base. There is a substantive evidence base on the effects of different implementation interventions, and there is an evolving evidence base for healthcare systems that can help us move the field forward. Future evaluative efforts are needed to focus on more transparent intervention development. So what we're looking for researchers to do is be transparent in how they're developing their implementation interventions, on how they are acknowledging or making transparent how they think the intervention will work and their implementation strategies will work. So better reporting outcome is what we're pushing for. For those that are on the call today, talking about perhaps how you're publishing your protocol so that others can use that protocol and build on that protocol moving forward, using tools such as the TIDER tool to be explicit about what are the components of the interventions you're working with, and following other types of reporting guidelines that are relevant to your study design. So that's it for me. Hopefully that's given you some food for thought and will help guide some of our discussion with the panel.
Thank you, Janet. Yes, so thank you for that great introduction and that recap of IS research. So with that said, we'll transition into the panel discussion phase of our session today. And again, thank you for Janet and Simone for co-moderating. So you should see my screen, and yeah, I'll hand it over to you both. So some of our for the first question, some of our panelists will have some slides. So we need a moment to bring those up. But yeah, with that said, I'll hand it over to the two of you.
Wonderful. Thanks so much, Pierre. And thank you, Janet, for such a great talk. It's always nice to hear, like, for me, a refresher, but just an overview of implementation science and all the different ways that it can be used. So that was great. So to kick off the panel, we just wanted to ask each of the teams to introduce their project for a couple of minutes, and also to introduce yourselves individually. And we've got a lot of people on the panel. So for each question, I'm just going to let you know how long we've got allocated for the questions, just so that we can try to keep to time. So for the introductions, we have 15 minutes. So if you could try to keep your introductions to say 3-4 minutes per team. So if we start with the Bridging the Gap team and hand over to Lucy and Kim to introduce their project and themselves.
Sure, I can't share unless you take down a slide. Thanks so much. And I will introduce us. Kim has agreed to join me to present. Sharon McCary was originally intended. She's one of our parent advisors. She wasn't able to attend. Kim is our postdoc in the project, and so we are unfortunately not able to present with a parent partner. So in phase one, we actually did a study that looked at a parenting intervention for parents who are raising children with neurodevelopmental disorders and dysregulated behavior. And I did this project in collaboration with many people, but our co-PI was Patrick McGrath at IWK. And Patrick is associated with the Strongest Families Institute, so there's kind of a natural way for them to implement this project and make it available. And so we kind of went a little bit broader and said, geez, the federal government, provincial governments, foundations are spending a lot of money developing non-medical psychosocial interventions, and some of which are proving to be quite effective. And what happens? Like, how do these projects get taken up? What do decision makers in Canada think of? What kind of decision-making process do they go through in landing on the adoption of one of these non-medical psychosocial interventions? And so we identified 3 research questions that focused on both decision makers and scientists. Asking about what criteria and processes do Canadian decision makers use in choosing to implement a psychosocial intervention. And then we also were interested in knowing from scientists who were developing and conducting research on these interventions about what they think happens when they design and test and attempt to scale their interventions. What criteria and processes are applied, and then what are the system level factors that hinder or help the uptake of these new psychosocial interventions? So what we're actually doing is we're looking to locate the Waldo, to locate where's Waldo, like where are the decision makers in Canada that are in a position to adopt the kind of non-medical psychosocial interventions that we're testing, and what do they go through, in what kind of barriers, facilitators do they face in the adoption of these non-medical psychosocial interventions, and then again getting a sense from researchers what they think those are all about as well. So that's our study. I'm just as an aside, I'm at the McGill School of Social Work at McGill University, and I'll have Kim introduce herself. Go ahead, Kim.
So I'm Kim McIver. I am a postdoc with Dr. Patrick McGrath at IWK, and I joined this project back in August 2023. So we're a year in, and like Lucy said, it's been a massive canvassing project, just knocking on doors, virtual doors. So emailing institutions, emailing scientists and organizations across the country, reaching out by phone, basically by any means possible. So, getting colleagues and friends to also provide contact names or reach out on our behalf to try to find decision makers, and as well try to find scientists who are developing programs, who are trying to get their programs out into the public sphere. So we originally started the project. We had a group of parents from the Strongest Families project who were already established, and it was really great because we were able to have many of those parents continue on for the second phase of the project, and they've contributed enormously to helping us understand what are the questions that they really want to have answered in this study. And then we added a youth from the from Childbright to that committee as well. And then we also added some decision makers who are connected in various ways to different governmental organizations. So we really benefited from that, and our and we're now at the phase where we're collecting data. We've got our study or our study survey out there, and we've collected 95, or we have had 95 people log on and either complete or attempt to complete the study. We've got 370. We've sent the link to 379 people. And then we have also reached out to many more individuals and spoken to many more individuals in meetings and phone calls across the country to share information about the study, share information about Childbright. So we're at the point right now where we're collecting data and we're getting ready to move into interviews, semi-structured interviews with the people who have agreed to be interviewed. So not all have agreed to be interviewed, but we have 34 of the individuals. We've got 23 decision makers and 11 scientists who have agreed to do semi-structured interviews with us. So we're just in prep for that at the moment, and then also preparing.
Amazing.
And also preparing to publish our protocol. So.
Yeah, awesome. Thank you so much. This is such an important project. I'm interested to hear your answers to some of the questions as we go through. But maybe we'll now move on to speaking to the congenital heart team. So we've got Marie-Eve, Kelvin, and Jamie Lynn. If you wanted to spend a couple of minutes talking about your project and then introducing yourselves.
I guess I can go first. Hi, everyone. It's a pleasure to meet all of you virtually. I'm Kelvin, and I'm a research fellow with Dr. Mike Seed at Sick Kids. And I was involved in the phase 1 match study where we explored the safety and feasibility of maternal supplemental oxygen to support in utero brain development in babies with congenital heart disease. And by the time we wrapped up the study, we found that the study or the intervention was safe and feasible, but we did a secondary analysis and it didn't really reveal any significant developmental benefits. And so because of the lack of evidence, we decided not to move forward with a larger randomized control trial. However, we did find some compelling data from this trial regarding poor neurodevelopmental follow-up rates, which sparked our phase 2 project, which I'm looking forward to discuss later. And I'll hand it off to Jamie now, who's our patient partner.
Good afternoon. My name is Jamie Lynn Hunt. I'm a very proud mom of 3. I became involved as a parent partner following the diagnosis of my son's heart condition, HLHS, or hypoplastic left heart syndrome. Once confirmed and transfer of care to our specialist team occurred, I was approached by the match study and asked if I would consider joining. I happily did, as naturally I wanted to help my son any way possible. I also wish to help improve care, intervention, and follow-up for children living with CHD. Participation in phase 1 was incredible. I was met with exceptional care and support. I wore oxygen for as long as possible and kept accurate account of time and duration, as well as any symptoms that I had. I received telephone calls weekly, as well as occasional diagnostic imaging and ultrasound testing for data collection. I was very well supported and very happy for the opportunity to participate. Thank you.
Hi, and I'm Maria Bullduk. I'm a postdoctoral fellow working on the phase 2 project. So we thought it was important to draw, because of the topic of today of moving from phase 1 to phase 2, we thought it was important to draw the continuum of what happened in phase 1 and phase 2 for our project. So our phase 2 project is to develop recommendations of care pathways for the developmental follow-up of children and adolescents with CHD that are adapted to the Canadian context. So right now, what we have as gold standards are American recommendations that have been, as Kelvin was saying, the uptake is really poor. So what our plan on the right side of this slide is, so we first worked on protocol development and ethics approval. And unfortunately, we're still in the first two steps of our project. We've faced different administration hurdles. But we've been able to work on a knowledge synthesis. So what we want to do is to kind of summarize everything we know about neurodevelopmental follow-up for children with CHD. And our process will be a nominal group process, and then knowledge mobilization. So maybe if we can move to the next slide. I'm trying to go really quick. It's hard to describe such a big project in like 2 minutes, but so the nominal group process is a process where we're going to try and understand better what the barriers and the context is for implementation of neurodevelopmental follow-up in Canada. So we'll have at the same virtual table, we'll have patients, so youth with CHD, parents, healthcare professionals, health decision makers, administrators, and hopefully all the way to politicians who can actually open some more opportunities for funding. But we'll ask questions and we'll have a voting process to develop a consensus of what is feasible and acceptable within the Canadian context, because we know it's so different from what we see in the US in terms of our populations, our geographical areas. And so that's the process that we want to do to make sure that we understand well so to improve the implementation of neurodevelopmental follow-up. And the last slide, please. And what we've found too is that one of the biggest challenge for neurodevelopmental follow-up is that there's so many kids to be followed. And if we look at the American recommendations, a lot of professionals here feel that it's going to be very difficult to follow all of these children. Even in the US, the follow-up rate is about 29%. So what we're working to as a kind of secondary project is to take all the data from the different centers in Canada and also in the US. So we have access to more than data on more than 1,000 children that have been published, but nothing has been done with this data. So what we want to do is to develop a risk calculator to help for the triage of who needs the most, or who's more at risk of neurodevelopmental adverse outcome, and then be able to use that to prioritize people. So that's kind of our project in a nutshell, and happy to answer questions later.
Great, thank you so much, Maria and team. It's super interesting hearing about how you've gone from phase 1 to phase 2, and it actually hits on our first question, or our next question, I should say, our second question for this. So we can unpack some of this maybe a little bit more. And Jamie Lynn, it was really amazing to hear your experience as a patient or a participant in this research in phase 1 too. So now let's move on to the pain pathway team and just hear a bit about their work and an introduction to Sharon and Lisa.
Sounds great. Thank you, Simone. And thank you, Pierre, for pulling up our slide. Hi, everyone. My name is Sharon. I'm an assistant professor in the Faculty of Education at Simon Fraser University in Vancouver, BC. My educational background is in clinical child and adolescent psychology. And so clinically, I'm also a registered psychologist at BC Children's Hospital. I joined the pain pathway team as a postdoctoral fellow, and I'm continuing my work with the group as an early career researcher and co-investigator. I'm very happy to be here to share with you some of the work we're doing. And I'm here with Lisa Kim representing our team. I'm going to let Lisa introduce themselves, and then I will share an overview of our project.
Hi, everyone. Thanks for having us today. My name is Lisa Kim, and I'm a parent partner that works with Hal Seiden and his research team, embedded in his team at BC Children's Research Institute. And then on this study here, I am a co-investigator and helping dive through this implementation plan here. Go ahead and explain, Sharon.
Yeah, thanks, Lisa. So, this is a project in phase 2 led by Dr. Hal Seiden and Dr. Stephanie Glegg. And so for some context, when we talk about the pain pathway, it's a clinical pathway or practice guideline that was originally developed by Dr. Hal Seiden and his co-PI in the phase 1 project, Dr. Tim Oberlander. And the goal of the pathway is to help manage the pain experience of children with severe neurological impairment. And we often refer to this pain experience as pain and irritability of unknown origin, so PIUO. And the pain pathway in phase 1 was developed and tested in a randomized controlled trial in tertiary pediatric hospitals across Canada. And so as Janet kind of presented to us, that's in a very kind of rigorously controlled environment where this was explored to test for its effectiveness. And so moving into phase 2, our aim was then to ask, well, can this tool now be used in more of a real world setting? For us, it was considering how can this be used by general pediatricians in a community pediatric practice setting across the province? Will this be useful? Will this be helpful to clinicians in a broader context? So our phase 2 project is guided by one of the theoretical frameworks for implementation research called the Active Implementation Frameworks, which really organizes all of our research activities into 4 integrated, like non-linear staged approach. And we have depicted that here in this slide. I know you can't see much of it, and I won't go through it in details, but our goal was to kind of show that the research activities have been embedded across different stages of development. And we wanted to also provide illustrations to help simplify kind of each stage of research activity that's going on. And to that end, our project, in line with Child Bright's kind of mandate and our principles, is to prioritize patient-oriented research, which means that we want to ensure that voices of people that bring lived experience in this area of work is represented over the course of our entire research project. We'll speak more to that in the next panel question. And we've also embedded an integrated knowledge mobilization plan, which meant for us that at every kind of part of our process, we wanted to be sharing and getting feedback about what we're doing, how we're doing it, and the findings that we're gathering along the way to our research team and to a broader audience. And so this depiction, as you see with our kind of illustration, is part of our integrated knowledge mobilization plan to share with everyone in different ways what's going on with our research and how can we help you understand what we're doing along our journey. We're using multiple methods across all the different stages of our project. That includes surveys, interviews, we're doing behavioral tracking, checklists, and site visits. And I think and we want to also give credit of this illustration to our Child Bright summer student, Hannah Huguet, who helped us develop this and many other knowledge mobilization products that we've already generated kind of in the early stages of our implementation planning. After this little presentation, we'll share a little link to our website that will kind of summarize all of this work, and you can kind of keep updated on our project along the way.
That would be great. Thank you so much, Sharon. Maybe if you could put that link to your website in the chat, that would be great. And then people can have a look at that as we go along.
Yeah.
But yeah, a great overview of the work that you're doing, and look forward to unpacking this more as well in the coming questions. And just moving now to the virtual reality for executive function project team to introduce themselves and their project. So we've got Jennifer and Gunjan.
Great, excellent. And I'm just going to share my slide if that's possible. 1 second. Share screen. There we go. All right, you know what? It's not sharing, so I'm just going to go ahead without it. So the virtual reality project is phase 2, and it it lends itself from phase one, where we are working with the National Research Council, and we're looking to see whether or not executive functions can be trained using virtual reality. We are using a type 2 implementation, as has been previously described. So we're really looking to see whether or not the intervention can be implemented effectively, as well as validly within our population. We've already completed youth co-design and integration with our people with lived experiences. We've done some initial feasibility and tolerability just within the sort of the implementations of the task themselves, as we prepare to soon launch our feasibility implementation trial, where we will be sending out the headsets to families in their homes. And that's going to be a big piece of how we measure the implementation element of the trial itself. We have sort of exciting new collaboration that's somewhat outside of the Child Bright Network, but I think is going to be really important for really thinking about how this kind of intervention can be translated and disseminated broadly. So that's with some new collaborators at Saint-Justine. And it will really give us an opportunity to look at how the effects might be spread across different populations, as well as having some opportunity for translation. And so next up for us is actually going to be starting our trial phase. And moving forward, we have a great youth and parent council, and one of our members is today, and I will hand it over to her to introduce herself.
Thank you, Dr. Crosby. Can you hear me? Wonderful, thank you. Thank you everyone for such a lovely presentation, and thank you, Dr. Janet, for sharing the wonderful presentation about implementation science. So I will be very precise and short. I'm a mother of an amazing, lovely boy with autism and ADHD and a proud immigrant. I got connected with this project in phase 2. Before I did some review of the grant, I was reading it, I was making some notes, and it was so meaningful for me as a mother because the theme was so powerful, it was so meaningful, and I showed my interest to collaborate in this amazing work, and then I got connected. So this is me in short. I'm very, very excited, very privileged, very honored to be a part of this amazing team. Thank you. Thank you.
Wonderful. Thank you so much. It's so great to hear these amazing projects and what's happening. So we've all kind of touched on, or you've all kind of touched on sort of how you've moved from phase 1 to phase 2 and reframing your research. So I want to focus on the second question that we have here on the screen about the lessons that you've learned in making this transition from doing effectiveness research in phase 1 and moving into implementation research in phase 2. And maybe could we start with the congenital heart team and hear your reflections on what you've learned in this transition period?
I guess I'll start first because I'll just briefly talk about phase 1 and then we'll talk about how phase 2 came about. So when we concluded phase 1, our secondary analysis did show there was no significant benefit with neurodevelopment using maternal supplemental oxygen. And so we didn't directly move towards direct implementation. However, we discovered that around half of the control group, so these were patients that were cared under routine care and they were not part of the trial, about half of them that were eligible for neurodevelopmental follow-up didn't come to neurodevelopmental follow-up at 18 months of age. And this was concerning to us. And so this highlighted that many children were still missing out on critical follow-up and developmental care. And at the same time, similar results were published from the CNOC registry, where only 29% of CHD patients attended their neurodevelopmental follow-up. And so these findings combined with our phase 1 data led us to develop phase 2 under the Child Bright Network to create Canadian recommendation guidelines for neurodevelopmental follow-up, as well as a potential risk stratification tool to improve developmental care for children with CHD in Canada.
Great. Thank you so much, Calvin. And Jamie Lynn, did you want to add your insights into the lessons learned in this transition period?
Yes, I will. So I met again with Calvin and Marie-Eve at the Child Bright Conference and decided to continue my participation as a parent partner, transitioning from phase 1 to phase 2. It's very exciting as we look forward to showing you today, and we'll unpack that a little bit more as we move on. But the objective moving forward, as we develop recommendations of care pathways for the developmental follow-up of children living with CHD. So we had a long and lengthy discussion about problems and difficulties meeting all of these appointments as a parent with medically complex children. And so we're hoping to improve that statistics of 29% and to achieve better, because we know that the outcomes for the children will be better. So we'll unpack that more leading into question 4. Thank you.
And maybe just like on my side, the most important lessons that I've learned was how much time it takes to build a network and develop the relationships that are needed to really have an implementation that will be successful. So in our case, we're thinking about changing practice across the country. So we want to have recommendations that will be feasible and acceptable in multiple centers, thinking, of a model that currently almost only exists and in centers that do open heart surgeries, and to see, is there another model that is possible? And having a strong network of people will be essential when we move into the implementation phase and future studies. So to me, that's the biggest thing that I've learned through this, to the transition to phase 2.
Yeah, great. And I'm just reflecting on the comment from Jamie Lynn about how parents have a lot of appointments that they do need to attend. And so is the number of appointments that parents attend, is that something that you're factoring in when you're thinking about the implementation strategies for this pathway?
Yeah, for sure. So we have a panel, or we have like a patient and youth partners that help us with this study. But also as part of my PhD studies, that's one of the things that I did, and I was working with Annette Meinemer and Marie Bossard-Racine at that time, where we examine what current practices are in Canada, that we're showing that, we're only half of the centers that have open heart surgery actually follow up kids in a systematic way. But we also interviewed youth and parents with CHD, and the number of appointments was clearly something that stood out, as the parents are trying to manage everything. And like there's cardio, there's neuro, there's neurodevelopmental. So we really do need to take that into consideration. And that's why we think that they need to be sitting at the decision table when we make the recommendations, along with healthcare professionals and administrators.
Yeah, I totally agree. That's amazing. Thank you. And how about the pain pathway? What lessons have your team learned along the way?
Yeah, thank you. So phase 1 was really looking at this intervention of using this pain pathway to help these children in tertiary care centers, but to get this out into the community and have community pediatricians utilize this in their geography in different regions across the province, so that families aren't always having to come to the main hospital in their province, is really the priority of what we're doing. So to gain a better understanding of what would help make this successful in this different setting, we went out and are looking at gathering feedback from a number of different sources. So first we developed a parent monitoring board. So we have 5 families that joined our parent monitoring board that are families that moved through phase 1 already. So they were part of the phase 1 study. Their children went through the pain pathway themselves, and they've joined together, and we gather with them several times a year and over email and conversation with them, giving feedback on the protocol development and what it will look like to train pediatricians to use this pathway, and how it would best serve their families ultimately in the uptake of using this in the community settings. And then we also have a clinician advisory board that includes both practicing and retired community pediatricians. So they obviously bring a wealth of knowledge from their experience working in community practices, and reminding us of things that maybe we might have overlooked, different billing code informations, or how long appointments could be for seeing these children, different incentives that might be incentives for pediatricians to get on board and use this pathway. And so they've been really instrumental in helping us develop the protocol and the early stages of this project as well. And then we also did interviews and consultation with the nurses and physicians that worked in the tertiary care centers in the phase 1 part of our study. So we went back to them and really wanted to know what worked for you in this setting. What do you think is necessary to bring to the community? What might be challenging from your perspective to bring to the community? And then finally, where we're currently at in our project is we're doing a barriers and facilitators study with community pediatricians in BC. So we have a survey that's been sent out as well as an optional interview that they can participate in. And we have pediatricians that are filling out the survey and just giving their feedback on what their perception of barriers and facilitators to use this pathway in the community would be. And then we've been conducting interviews over the last couple months and just trying to really understand how best to go about this implementation and how best to even find community pediatricians who would want to take on the pain pathway themselves in their clinic.
It sounds like it's quite a comprehensive project, I suppose, and you've really considered so many things. And it sounds like, Lisa, you're so involved as a parent partner, which is absolutely wonderful. And I might have misinterpreted what you said, but I was wondering, it sounded like parents are involved in training the pediatricians that you're bringing into the study. Is that right?
Yeah, we haven't gotten to that part of the study yet, but we did just recently have a meeting with our parent monitoring board, and the question we're asking them is, what would you want pediatricians to learn about caring for your children? What is missing from your interactions with them? What would help you get the care that you need for your child in that setting, rather than having to always come to the emergency room or come to the tertiary care hospital. And I mean, BC, like all of our provinces in Canada, is wide geography, and a lot of people don't live right near BC Children's. And so finding a way that parents can access their own community pediatrician and get all of the same level of care in that setting is important.
Absolutely. This is great. I'm so excited that you've got parents so involved and involved with the training aspect as well. Sharon, is there anything that you wanted to add from your perspective about lessons learned?
Yeah, I think Lisa did a great job kind of summarizing everything that we've reflected on as a group. And one thing I'll add is, to that end, I think we're learning how important it is in phase 2 to focus on the process of preparing for implementation and really arriving at this perspective that it's about a partnership with the community and what we're doing. And that's our goal, right? That we're not trying to impose of an implementation tool. It's, what is this going to be helpful for you? And we need to understand from your perspective how we can deliver. And so I think that's been a really valuable reflection for us, and it's helped guide our work to date. So
wonderful, thank you. And moving on to Jennifer and Gunjan, and thinking about the virtual reality project, what are the lessons that you've learned in moving from effectiveness to implementation research?
So, for our project, it was, I would say for our team, like many others, really becoming immersed in the implementation science, measurement and methods and models to ensure that we were measuring it in a way that was going to be most informative. So I think that was a big shift from phase 1 to phase 2. We really worked hard to meaningfully pull all input from our families around the technology usage. So really a focus on, while phase 1 really was around validation, for phase 2, there's a real focus on that acceptability and feasibility aspect. So ensuring that we had pulled all of the qualitative comments and content that we had from families around the technology use had been pulled into our new design, which was really important. We intentionally have expanded our parent and youth group so that we have diverse perspectives from our people with lived experiences. And so while we did have some nice transition of individuals from phase 1 to phase 2, our actual phase 2 group is mostly new families. And it's really been informative and great to have some new perspectives, some new thinking about our design and what we're asking and how we're asking it, which is sort of constantly allowing us to think about the intervention, but really what are the key elements that we are looking at to facilitate uptake, because our design is a little bit different in that we are implementing right into families' homes. So that perspective is really important of what families, are interested in learning and understanding, and what kinds of questions are going to be asked. I think the other piece that was unique for us that we pulled from phase 1 to phase 2, but actually how you measure some of these constructs as it relates to virtual reality. It's such a new methodology that a number of the measures really had to be adapted quite a lot for children. So we spent a lot of time doing that kind of work, which I think has been really very interesting. But it shows that when you do novel technology-based work, you can't always rely on our traditional tools to do that. So there's been a lot of kind of focus on how we have these tools that are meaningful and are going to answer the questions that we have. Gunjan, would you like to add in some additional thoughts or comments on sort of I know you were involved with phase 2, but if you have anything additional to add around the phase 2 work that we've been doing?
Wonderful. Thank you, Jennifer. Nothing much to add, but honestly speaking, I echo Jennifer's comment. It's all about how are we including the diverse voices. We have people with differential knowledge, but very significant knowledge. All are coming from differential experiences, lived experiences that are very powerful in shaping our work. And we're also practicing those observations at our homes too. I'm actually trying to use this with my son. So it's just a different experience, how I'm including everyone in my family to have that experience and share those observations with the team.
Yeah, absolutely. And that was actually going to be the comment, and the question that I had is around bringing in new partners. So there's a lot of value, obviously, in bringing through a core team because they bring a lot of knowledge with them, but also recognizing the value of variety, of bringing in new partners essentially, and the additional things that you learn. And it's great, Gunjan, that you're also using it with your son, and because that just gives you like another level of variety. And I think it's something else that we talk about, I know, especially in the research teams that I'm in, about how do we make sure that we have enough representation in our parent and youth partners, and making sure that we've, like one person brings one perspective, and just broadening out the perspectives that we bring to the table. And I wonder, Jennifer, if you wanted to comment on how you went about finding additional parent and youth partners. Was it all through ChildBright? Did you have other? How did you go about doing that?
So it was for a number of our new members, it actually was through ChildBright, which was great. And I think what was helpful there is that a number of the families who were involved, while they were new to our team, were not new to kind of consultation on teams, which was very helpful. One of the things that's unique about not just ours, but others as well, is we did a youth co-design, and so for studies that go on longer periods of time, youth naturally are in transitions. So of course, if you're dealing with youth might have time while they're still in high school, but then they go on to whatever they're going to do after that phase, depending on where they are. So I feel like there's more of a natural transition of youth, and sort of thinking about that in the life cycle, and maintaining the continuity while also getting kind of some unique perspectives. So we collaborated with ChildBright, but it was one of the pieces that I would say is sort of in the future, I will keep an eye on that and kind of planning for, as our youth
transition out. And I know from some of my other groups, some of our youth have transitioned out, and then sometimes they come back in. So we've actually had some youth in another study I'm on kind of leave for a little while, and then as they get kind of settled kind of back into the next phase, they've come back, and they definitely have more of a different kind of perspective as they've gotten a little bit older on the research that's being done. So yeah, that sort of integration and the continuity across time, I think, is an interesting one, and there's value in both fresh voices, but how it gets managed and some continuity from across the different life cycle of the program. But for us, a lot of our new members did come through ChildBright, which was really helpful, and we were really fortunate to be connected with so many people who were interested in partnering with us.
Great. And we've just got a question from the audience. Alex?
Oh, sorry. I think that was a misclick.
Oh, okay. No question. That's okay. So we might move to the next question now, just in the interest of time. So the next question is around sustainability. And so I'm wondering if the teams could reflect on, as they've been designing and planning these implementation science research projects, how were you thinking about sustainability at the start? And sustainability being making sure that once your research is done, is that the people that are meant to be doing the intervention are still doing it. And what kinds of things did you think about for sustainability? So maybe if we throw open to the pain pathway first.
Yeah, I can start us off. For us, we thought about, so our evaluation framework is we're using the RE-AIM framework. And part of that was discussing whether or not sustainability would be part of our research aims. But given the focus of us kind of taking on a hybrid design, wanting to evaluate the intervention outcomes and the implementation outcomes, we ended up designing the sustainability component kind of at the latter end of our project. So kind of in the fourth and final stage of our implementation, we're starting to ask questions about what are going to be the factors that are going to help maintain this plan after the end of the project. And so we set it out to be more of an exploratory basis to consider what are going to be those factors based on the data we've collected to that point. And I think we've embedded that as kind of a question we'll ask to explore those options, but not so much as where we'll end up with a sustainability plan, much more as what are the steps that we're going to take to build that sustainability plan for a subsequent phase. But it's been important for us because given that our main question is about would this be a feasible and acceptable tool to use within a community context, we thought a lot about the implications of this. And we have a few examples of how we've brought that into our conversation. I think Lisa's going to share a few examples of that.
Yeah, so the first piece here is in phase 1 of our study, we had a study nurse that was part of the study, and the study nurse helped the physician ordering tests, chart reviews, following up with the families weekly, collaborating on type of care to be delivered. And the feedback we got from both the physicians and from the families that were part of phase 1 was that this was a really important part of the study of going through the pain pathway, was having this nurse. And so we want to integrate having a nursing intervention for phase 2. But of course, in adding that, we're also recognizing that not every pediatric community clinic is going to have a nurse available. And so we are supplying that nurse for the study itself, but are also exploring how can we have a complex care nurse or something of that extent that would be accessible for community pediatricians to collaborate with this type of care going forward. So that's an ongoing exploration. And then another piece that we've looked at, we mentioned geography earlier, being a really important part of our province and our country, and how far people live from the care that they need to access. And so we've also been looking at undergoing some geomapping to understand both where community pediatrician offices are located within the province, but also where children and families that have medical complexities that might present with these pain symptoms in the clinics are located and where they're living. And we want to be sort of strategic and aware of the reach that we might have in choosing which pediatricians will be implementing this pathway, and that it would be able to reach the most number of people.
Yeah, that sounds so important. And it comes back to some of Janet's comments around like choosing an appropriate design, right? To be thinking about, well, how can we test the value of having these nurse navigators? Like how essential are they? And thinking about how we can do that for sustainability. And handing over now to the congenital heart team. We're down to the last 10 minutes, and it'd be great if we had time for a question or two from the audience as well. So what are your comments around planning for sustainability from the outset of your project?
Jamie, did you want to say a word about this?
Yes, I will.
Your
Thank you.
perspective? Thank you.
Yes, I will. Thank you. So, from a parent perspective, barriers to developmental follow-up, there are many challenges. And a brief overview are financial, distance to travel, transportation needs, lack of support, feeling overwhelmed, accessibility, taking time off of work, multiple follow-up appointments on various days, and then also equitable care. So I live in a very rural farming community, so it's a lot of traveling for specialist appointments. And then also if there are multiple appointments, it's challenging to get several days off of work. I know parents would prefer to just lump all of the appointments together, and just understanding that this is a day of appointments and you make the day of it. So I'll hand it over to Marie-Eve, and she can continue the presentation on the final information. Thank you so much.
Thank you. Thank you so much for sharing that perspective. And from a research perspective, it's like for us, it's really interesting because we come from a place where the recommendations have been made and implementation has failed. So there was no uptake from the recommendations that are there. So our project mainly focuses from our perspective on sustainability. So how can we go back and reassess barriers in context, especially those of parents, because there's like really I think that was a shock for a lot of people that even, like one problem is that access to follow-up is missing, but even when offered, it's not all patients will actually go to follow-up. And that's, I think for us, like to me, it shows that we failed at one point to design recommendations that take into considerations the barriers that families face. And how can we do better to have more accessible and equitable care across the country? So our project is mainly based on this. And so we're looking at the different factors, and in some of the sidelines, what we're doing is trying to build networks that will be the leaders across the country to make sure that they will be uptake, there will be leaders, there will be champions who will then take on those recommendations. So we have a new heart and stroke grant that is actually creating a network of clinicians and researchers working with congenital heart defects. We've been members of committees that work on the North American level, trying to change ways that we do developmental follow-up so that it's more accessible, equitable. So it's kind of really working on all of these different aspects to make sure that once we get in there, then it's going to be there for the long run. Because especially like even for now, a lot of the earlier clinics were based on research funds. And that again is not very sustainable. So if the research funds go, what happens to the clinic? So we really have to take all of that into consideration. Yeah,
absolutely. That's and I think your recommendations will be so important for a number of different patient groups, right? Like it's not just the congenital heart defect population that face many of these challenges that you're talking about. So I'm super curious to see what your recommendations are when you get there. Gunjan?
Sorry, I can't resist because this is something very, very close to my heart. I go to spaces as a parent partner and we talk about sustainability every time. So this is something very I'm passionate about and like to share something from the very basic. if we really need sustainability about anything, we really have to stick to the core values of partnership, which is mutual respect, clear communication, authenticity, compassion, and much beyond that. When we go with a strong foundational values, we can definitely go for higher sustainability of our practices and work we do together. Just in short, and my sincere apologies myself. Thank you.
Yeah, absolutely. Thank you so much. We have maybe just a couple of minutes. Are there any questions from the audience? You can put your hand up and unmute, or
They can be questions or comments or observations based on, you know, all of what you've heard today.
Annette?
So I just first want to just congratulate all the groups for their transition from phase 1 to phase 2. I think our researchers certainly were much more comfortable in their roles in phase 1, and phase 2 really presented a challenge because we lacked that expertise. So we're very grateful to Janet and to the others that came into the network to really help guide us, and the postdocs have been incredible in facilitating that transition as well. You know, we learned a lot about patient-oriented research and really the authenticity of engaging partners in every aspect of the research cycle in phase 1. But I was worried about phase 2, given that it's such a different type of research, harder to understand, harder to navigate, like for all the players. So I'm just so thrilled to see the level of engagement of parents and youth in all these projects. That's really a message that came through very strongly in the panel. So I just want to congratulate all of you, and it just I'm just
I don't know. It was the one on Pender Island.
so it's just really more of a comment.
Thanks, Annette. I absolutely agree. It's so amazing to hear how involved the parent and youth partners are in this phase. Celia?
Echoing Annette, it was really a really interesting session and great to see everything. My question actually ties in a little bit to what Annette was saying, and mainly for the parent partners, but what do you wish that you knew about implementation early on, or somebody that's new to working in as a parent partner in an implementation science project? What would be some of the pieces that you would want to know about implementation science right from the beginning, now that you've worked in it for a little while?
Yunjin, did you want to take the floor?
Yeah, thank you. So I know I'm very passionate about implementation science. So imagine it's something that is gaining a lot of attention from many parents, partners, and from many researchers and clinicians. Parents are hoping as a lived experience partners to start from like a baby. So teaching them just A, B, C, D, and then building on that. Listening their best hopes in this process and being curious and inviting their curiosity in the process. So just creating a basic definition about implementation science, a kind of a layman language, may be the beginning of the foundation of this process.
Wonderful, thank you. And Lisa?
Yeah, just add to that, speaking more lay summary type language for parent and patient partners. I think one of the things that many families that I've spoken to resist research is because they can see how much research is done and how little is actually utilized and implemented in the real world. And so I think this type of research is actually something more parents would get behind and would be really excited about if they can see that we're doing research so that the studies and the information and all of the data that we do have is actually used in the real world. And so I think just sharing exactly that would get parents and youth excited about it.
Great, thank you. And Jamie Lynn, did you want to have the final word on this, and then I'll hand over to Pierre to wrap up and sign off?
Sure, thank you. I would say that was all summarized very well, and that essentially I concur. The language needs to be understandable. Like, we are not cardiologists or like professional researchers. So I think it's really imperative that the language be understandable, and that the parents know what the ultimate goal is and what we are trying to achieve. As a parent with a child with a heart condition, I want to see that things come to fruition, that it is making a difference, and that it will be impactful for my child's future and treatment. So I'm very passionate and I want to see things happen. And I do understand sometimes, things don't turn out as you hope, but it's not all negative. It just brings you a step closer to the answer that you want to find to improve the care and the treatment. So I thank everyone for their involvement and for their continued work in advancing treatment. Thank you so much.
Simone, if I could make a comment before you pass it over to Peter.
Yeah, please.
And I was just in listening to this discussion, it was so apparent to me how powerful this network can be in shifting the needle towards how can we do better implementation research in children's health. And I'm so passionate about each of you reporting in as much detail as possible your experiences in your project, so that and it shouldn't just be in one manuscript, it should be in several manuscripts, so that others can learn by what you did and build on that going forward. And maybe what you're doing is saving time for other teams to not have to do some of the steps that you've done. So I just want to comment on the importance of reporting on your work and reporting on the various pieces of your work to build the evidence. That's it.
I agree totally. And also reporting on what's worked really well, and a lot of things worked really well, but I'm sure there's a whole number of things that haven't worked so well, and encouraging you to be brave and publishing both sides of what works well and less well. But with that, we've got 1 minute left for Pierre to have the final say and wrap up for us all.
Thank you. I just want to take a chance to thank you all for joining today and attending this session. Special thanks to Janet and Simone for helping facilitate the discussion with the panelists from all 4 projects. Looking forward to learn more. Looking forward to hearing more of the impact that all these projects have down the road. So I guess everyone stay tuned, and we'll follow along as you will track on with your research proposals. So in the chat, I've quickly added a feedback survey. We will circulate this again after the session to you all, along with the recording of the session today. But yeah, if you want to take a moment and just let us know what you thought has worked well with any of the sessions you've attended to date, that'll be great, and we can certainly learn from that, work on it, and we'll put on the next session, the next event. We can certainly incorporate those elements in the output. So again, thank you so much for taking the time to join us today. Now it's a long session, but what was shared was, I think, super exciting, and looking forward to hearing more. So thank you so much. Have a good day, and we will connect again soon. Bye.
Thanks, everyone.